Good afternoon, ladies and gentlemen. I want to talk about risk stratification in the COVID-19 pandemic using analysis of heart rate variability. My name is Professor Rainer Buchhorn. I'm a pediatrician, and the last 25 years I investigate heart rate variability in children. And now I take the opportunity to demonstrate the first case who was monitored with heart for analysis during COVID-19 disease. Analysis of heart rate variability is not really new. There are reports about Chinese doctors who use pulse diagnostic to predict the death of their patients. But today we have new technologies to analyze heart rate variability, for example, with such an 24-hour Holter ECG. Most of our studies based upon this technology. Moreover, today everybody has the opportunity to measure his own heart rate variability with a fitness tracker, and sometimes our patient will understand more than the doctors how to use it. The newest technology is to monitor heart rate variability in an intensive care unit setting. We have self-made technology to monitor our patient on a pediatric intensive care unit, but there are professional systems used in this setting. First of all, we have to understand that we use a normal heartbeat, the so-called sinusoidal rhythm, to understand the main regulatory system of our body, most of all the limbic system and the hypothalamus-hypophysis axis. That is an important issue to understand that we use the heart to understand the brain. The method based on the difference between the single heartbeats or NN intervals to analyze the variability with statistic methods or the fast Fourier analysis. This chart is showing heart rate variability during the human life cycle, and there are important changes, most of all in the first 15 years of life in childhood. The chart illustrates the fast Fourier analysis with the very low frequency power illustrated in gray, the low frequency power illustrated in red, and the high frequency power illustrated in green. The high frequency power represents the vagus activity, although as a time-domain parameter RMSSD. The other parameter illustrated is the SDNN value that illustrates the global heart rate variability and may have a great impact on prognosis. And the other is the heart rate with high values after birth decrease until puberty and stable heart rate until the end of life. Today, we are able to monitor our heart rate and heart rate variability, for example, with the Apple Watch Series 4, but other fitness trackers also monitor heart rate variability that use the pulse wave to have for analyzers. There are two fitness trackers who have good ECG registration. It's the Apple Watch 4 and the Xiaomi Mi Band 3 with very good results as shown in this slide. However, our favorite, not on market today, is the LifeTrack Zoom HR4 that monitor the RMSSD value. That is the only fitness tracker who monitor this value, and we found a very good association with a professional system in the Holter ECG and the LifeTrack Zoom HR4 and red dots. Now to our case is the first published case of RFR analysis during acute COVID-19 disease. It's a 50-year-old pediatrician. He has SARS-CoV-2 PCR positive and antibody positives, and a disease between the 10th April and the 24th April 2020. The symptoms are medium with a loss of smell and taste, severe body pain, fatigue, fever, and cough. He's monitoring his stress level with the Samsung Health app. He monitored his heart rate with live track Zoom HRV, and he used a HRV monitor with the Pathfinder Holter ECG during the disease. Showing this slide illustrates the data of the Samsung Health app, and in the first early disease, the stress level seems to be very low. The same data were measured at late disease, and later, during recovery, he developed his normal stress level. This chart is showing the detailed HRV analysis with the Holter ECG system between the first day of the disease and the recovery at the 16th day of the disease. The mean heart rate seems to be unaffected, as well as the vagus activity indicated by the green area of the fast Fourier analysis. However, there is a decrease of global heart rate variability indicated by the SDNN value and the total power of the fast Fourier analysis. In the first publication, we can show that the patients have very low global heart rate variability indicated as total power, but he didn't show the increase of heart rate during COVID-19 that normally is related to heart rate variability. The patient had more than 15 Holter ECG during the last 15 years, and there is a clear relationship between the total power and the heart rate. If the heart rate is low, the heart rate variability is high, and if the heart rate is high, the heart rate variability is low. This relationship is broken during COVID-19, as published in this paper. We try to develop an algorithm to predict the complication in COVID-19, and we use a plot of the global heart rate variability, SDNN, and the difference of the heart rate at day and night. The heart rate difference, the circadian heart rate difference. These are all the heart rate ECGs from this patient at baseline with the heart rates and during COVID-19 in the quarters, although with very low heart rates compared to the other heart rate. We speculate that there is a critical window for COVID-19 complications that are not reached from the patient. If we evaluate the algorithm with the normal values as published in the literature or our own values in children, there is a clear decline of the relationship of the SDNN and circadian heart rate difference with an increasing age. And this may explain how older patients have a higher risk to have complications in COVID-19 compared to the young patients who are far away from this critical window. We now evaluate this algorithm in a boy with a severe neurologic disease who had a SUDEP-like sudden collapse of ventilation at the age of 5.4. This is his life from the 4 years of age until his death was 10.5 years. At the ventilation collapse, he decreased his heart rate variability, and after intensive care unit therapy, he recovered and had higher heart rate variability until his death with the age of 10.5 in a palliative setting. Looking to our algorithm, these data clearly show the more critical the patient's condition are, the lower these data, and all these data are in the critical window of complication, the SUDEP-like period in gray, and the palliative setting during the end of life in with black dots. If we use this algorithm in our data from our online monitoring on our intensive care unit, we see again that those patients who have a fatal outcome or a transplantation are within the critical window, and others who survive their disease are far away from this critical window of heart rate variability. We further prove our algorithm in a big group of patients with operated congenital heart disease. Only 15 of these patients are within the critical windows, and we hope that we can say the most patients that they are safe and have a lower risk for complication of COVID-19. We further prove our algorithm in a group with obesity over the 96th percentile, and again there are 7 patients who are in the critical window for COVID-19 complication, and perhaps the other patients with obesity have a lower risk. Taken together, this algorithm has to be proved in a real-life setting in adults, but from our view, it is a promising tool to predict the risk for COVID-19 complication during the current pandemic. What happens with heart rate variability during long-term follow-up of our patient? He is wearing the LifeTrack Zoom RFR more than 2 years, and we compare the data from 2018 with the data from 2020, and there is the RFR score show the decrease of heart rate variability the month after the COVID-19 disease. And then he recovered to normal values. The heart rate data are very similar in 2018 compared to 2020. There is a low heart rate during the disease in April. And last but not least, these are the steps counted by the LifeTrack Zoom RFR, and there is lower steps within the disease in April 2020, and he recovered to normal values after the disease. In my opinion, the current uncertainty of being able to make statements about the individual risk of a patient is a major problem of the pandemic. It is unethical to unsettle high-risk collectives like children with congenital heart disease or obesity. As long as detailed epidemiological data are missing, our algorithm could help to make individual risk statements. However, don't wait on your doctor. We have chosen an algorithm that any fitness tracker can calculate. It is now up to the manufacturers to make the simple algorithm available to their user. It is now your job to forward this video and put pressure on the manufacturers. I wish you success, your runner.